Good morning, everybody. I'm Dawn Genvy, and I'm a research manager in the Patient and Public Involvement team at NIHR. Welcome to the ninth in our PPI in Action webinar series. Today's presentation is focused on the benefits of public engagement in surgical research, the design, delivery, and troubleshooting. Before the presentation, I'm just going to very quickly run through some housekeeping rules. Next slide, please. Please use the chat function if you'd like to network with others on the webinar. We won't be monitoring this, so it literally is a networking function. Please use the Q&A for the questions that you have and post them in that area instead, please. You can enable captions by clicking on the CC button. Next slide, please. And as I just mentioned, if you'd like to ask a question, please use the Q&A function by clicking on the Q&A button. You can select to send anonymously if you do not want your name displayed with your question. Once you've finished, remember to click send to submit it. Without further ado, I'm now delighted to hand you over to Professor Matt Bown.
Morning, everybody. As Dawn's just said, my name is Matt Bown. I'm a professor of vascular surgery at the University of Leicester. And in fact, this whole team is from the University of Leicester. We're actually talking about quite a lot of work that goes beyond the work we've done in Leicester. And this is really where this all started. So this was a piece of work that was commissioned by the Vascular Society of Great Britain and Ireland and led by Professor Ian Chetter from Hull York Medical School. And this is where our journey in vascular surgery in PPI really started. And this was a James Lind Alliance priority setting process that we ran. And now this started in 2018. And this has led on to a lot of things we're going to talk about today. So what we did in that priority setting process was, it was a classical James Lind Alliance process. We actually did 9 separate priority setting processes within that for these 9 disease areas. And so we got together, each of these disease areas was led by different individuals. So I led the aortic disease one with my colleague, Colin Bicknell from Imperial. Thanos, who's on the call today, he led the peripheral arterial disease PSP with Paddy Coughlin in Leeds. And what we did is we actually worked with members of the public to identify research priorities for each of these disease areas. We actually generated quite a long list of priorities for research. But this is the top 3 that came out through the aortic PSP, and they're all around sort of one of the common conditions, abdominal aortic aneurysm or aortic aneurysms elsewhere in the aorta, and really focused on the areas that we don't know about. So the benefit of running this PSP was that the NIHR actually has a rolling funding opportunity that is targeted specifically at James Lind Alliance priorities. What that has enabled us to do is that when we now write a grant in any of these disease areas, we can pretty much say that actually this is a public research priority. So it gets us beyond that first step in actually identifying the research topic as an important research topic. So like I said, that was run from 2018 to 2021. What we've now been able to do is through a lot of funding applications that have been coordinated nationally by the Vascular Society, we've got this large portfolio of, these are actually just the trials. There's plenty of other research going on that isn't actual clinical trials, but these are the major effectiveness randomized control trials that are now going on in vascular surgery. And these have all pretty much been driven by that James Lind Alliance process and funded by the NIHR and the British Heart Foundation. And as you can see, we've got a trial now for almost every condition we see clinically. So we'll sit in a clinic and almost every patient we see is eligible for inclusion in some trial or another. So that's been hugely successful. What I'm going to do now is I'm going to move on to and hand over to my colleague Thanos Saratsis, who's going to talk about one of those in particular and how PPI actually fed into the design of that trial. So Thanos.
Thank you very much, Matt. So I'm Thanos. Like Matt, I'm a vascular surgeon, so I treat people with various different health issues relating to their arteries or their veins. And I'm leading a trial called EVOC. Next slide. So this trial relates to how we provide better care and better treatments for people who have got blockages or narrowings in their arteries. This is a diagram of an artery where you've got some atheroma, you've got some plaque in the artery, which has led to a blockage. And these happen mostly in the arteries going to the lower limbs, the legs, and people can present in various ways. Next slide. So the one way in which people present is called claudication. That's when they get pain in their calf when they walk because of leg artery blockages. Next slide. But then we've got a number of people who present with something called chronic limb-threatening ischemia. So the blockages are very severe, and there's practically not enough blood going to the muscles to keep them alive, and they might require an amputation. That chronic limb-threatening ischemia process, which we refer to as CLTI, is the leading cause of lower limb amputations, both in the UK as well as most Western societies. So it's a big health problem. Next slide. So this JLA PSP that Matt discussed briefly involved 110 patients with claudication or CLTI and about 40 healthcare workers from across the UK. Next slide. In this process, we identified these questions as the most important research topics for people with claudication or people with CLTI. And to cut a long story short, people were mostly interested in how we improve outcomes after you've been diagnosed with this condition, and especially for the subset of people that require surgery or some other treatment in order to open up their arteries and improve blood flow to the legs. Next slide. So in order to address most of these questions, we need to perform some form of study, and most of these questions can be addressed in the best way, if you like, by performing a randomized controlled trial or RCT. Next slide. So what is an RCT? Essentially, you find people who have got a certain disease or a certain pathology, and you allocate them to a number of different treatments that have been designed in order to improve that condition, that disease. In most cases, you compare treatment A to treatment B, and you randomly allocate patients to receive treatment A or treatment B, and then you follow up the patients to look at what happened over the course of weeks, months, or years. And eventually, you figure out which treatment is better by comparing the results between the two groups of patients. Next slide. This is exactly what we're doing in the EVOC study. EVOC involves people who have got either claudication or CLTI, and we expect the vast majority of people included in the trial to have CLTI, to have either open surgery or keyhole endovascular surgery in order to open up blockages in the arteries that lie within their abdomen and within their pelvis. And these arteries are called the aorta or the iliac arteries. And we know that it's difficult to treat blockages in those arteries because of their location and because of various characteristics. Now, when we designed the study, the patients practically told us what is the most important thing that matters to them. And we involved dozens of patients with lived experience of this disease. And they told us that amputation and mortality, death, are the two most important things to them. So the study is designed in order to address whether the keyhole or the open surgery is better at reducing death and reducing the number of amputations that happen during follow-up. Then the patients also told us that quality of life is really important to them. So we've selected certain quality of life assessment tools with the patients that designed the study with us. And eventually they told us that they wish to be followed up for at least 2 years because they find that amputations and artery surgeries do happen very late down the line after you've had your original treatment. We're delivering the study in 34 NHS hospitals now, and we've just recruited 263 participants as of this morning, and we need to get to 628. Next slide. So I've deliberately kept this slide empty because we haven't just involved patients in designing the study and selecting the primary outcome measure and selecting the types of assessments. The study has struggled to recruit patients in certain areas of the country. So we've proactively involved patients in actually trying to look at why they might not take part. And we've designed new documents to help patients understand what's happening in the study a bit better. And now we've realized that patients also really worry about recurrent surgery or reintervention after the original treatment. And we're actually hosting a workshop in a few weeks in order to see whether we might have to change the primary outcome of the trial to also include reinterventions and not just amputations and mortality. So in a nutshell, EVOC has involved patients both in designing the study, funding the study, and now delivering the study based on their wishes. And that's about it, really, with regards to EVOC.
Yeah, thank you very much, Thanos. So I'm going to hand over to Imelda next, and we're going to have to just swap slide sharing in a second. So we'll just do that. So Imelda, if you want to share your slides. So one of the things that we learned through the planning of EVOC was that there was this need to have a lot of patient input into the design of research. And we became aware also at this time that actually when we conducted our traditional sort of PPI activities, they were very much based upon the local population. And of course, if I turn up in Leicester and speak to patients in Leicester, they always think the study is a good idea because I'm from the University of Leicester. So we became aware that actually we needed a much broader scale approach to PPIE. And that's what Imelda is going to talk about now, because on the background of studies like EVOC, we actually went ahead and did that. So Imelda, over to you.
Thanks, Matt. I'm Imelda. I'm the Vascular Research PPI Coordinator here at Leicester, and I developed and now lead the PPI registry. Just to mention at this point, there is quite a heavy focus on PAD patients in this presentation. We don't just have PAD patients on the registry, there are many different participants with different conditions, and everybody's input is equally as valuable and welcome. So in 2023, I was asked to create a vascular research PPI contact list, particularly focusing upon patients with PAD, because there have been difficulties in engaging this patient group within PPIE research. And we can kind of see why by looking at the characteristics of PAD patients. So most patients will fall into at least one of these categories, and many fall into more than one. So they tend to be older. Many have multiple health conditions. Often they have chronic pain, particularly when walking, and limited mobility. Some have frailty, and quite a few also lack confidence online. They don't really like clicking links or scanning QR codes, and they're not very keen on online groups a lot of the time. But why would these be barriers to engagement in the first place in PPIE? Well, because where we find these patients may not necessarily be the right place to get them involved and engaged in a long-term project like PPIE. So PAD patients have told us they don't really want to be approached and engaged in clinical areas, because when they're in these areas, they're quite often in pain, or they're in crisis, they're in for a procedure, or they're awaiting treatment results, and they're concerned about those. So they don't really want to volunteer for anything long-term at that point. Posters and leaflets in clinical areas don't really work either. There's a lot of informational noise in those areas, and cutting through that can be quite difficult. Social media is not the best place to find these patients. They may see adverts or promotions, but they're probably not going to click on the links for the reasons already mentioned. And in-person community events don't really reach these patients either, because of the chronic pain when walking and limited mobility sort of prevents them from attending these events. So I had to figure out a way of finding patients with these characteristics without focusing on these areas of trying to engage people. So when we sort of started out in 2023, there were already 2 PPI groups already up and running, with 15 participants in total across those groups helping. And Thanos also had 3 PAD patients who were regularly supporting him with research studies. All 18 of these participants did agree to have their name kept on the contact list, so we had a good start already, which was great. So at this time, I was also helping with a research study called LIM at Leicester. It was a single centre study working with patients with critical limb-threatening ischemia. And I was doing all the 1- and 2-year follow-ups for the patients. And many of them had also agreed to be contacted for further research purposes on their consent forms. So I gained permission from the study manager to contact some of the patients that I felt might be most suitable for PPI, and she said yes. So I sent out 90 leaflets in the first instance. I created leaflets myself, and I also wrote a handwritten compliment slip to every participant or every patient that I sent a leaflet out to, directed personally them, asking them to get in touch if they'd be interested in joining the registry. And we received 8 positive responses within the first month on the back of that leaflet drop, which was great, and continued to receive contact from patients over the next 3 or 4 months as well, having responded to leaflet when they were ready. So we had a few people now sort of with PAD who were on the registry and engaging well with the activities. Word started to get out through to external centres that we had PAD patients helping us, and that's when I found out that this was a problem that it wasn't just as Leicester who was experiencing, it was a problem engaging with these patients across the board, really. And researchers were asking me if I would be prepared to share the resource with them to help them with PPI for their studies. So, sort of we assessed those and said yes. But I also asked the external researchers if they'd be prepared to tell any PPI participants with PAD that they had about the registry and ask if they would like to join. So we got a bit of a trickle of patients in through external research centres who said they would like to join the registry. So we saw kind of organic national growth and development of the registry, both in terms of the research we were supporting, but also in terms of where the locations of the participants were. So that was lovely. We started to get a bit of a UK spread. In May 2024, about a year after the registry was properly established, I realised that I didn't have enough PAD patients. We were getting quite a few requests through from research centres, and I was having to go back to the same 15 people at that point all the time. There were 37 people on the registry altogether, but everybody was asking for the PAD patients. So what I did was contacted all 37 people on the registry and asked if anybody would be prepared to volunteer a bit of time to form a participant advisory group to advise me on promotion of the registry to reach patients like them more effectively. That was very successful as well. 11 people out of those 37 did agree to join the group. This is a picture of our most recent meeting in September. We have meetings every 3 months, have done since May 2024. And the participants have co-created and advised on every participant-facing material that we now use on the registry. So they've helped design everything from the logo to the brand to the information leaflets, which they've rewritten. We've got a YouTube channel now. There's been all sorts of work going on. They've also instigated 2 press releases, the second of which was picked up by a couple of national news channels, which was absolutely brilliant. And so as you can see, that participant engagement leads to further innovation, further targeted messaging, and we start the cycle again, which is fantastic. In February 2025, I sort of stopped to evaluate the progress where we were. So from those 37 participants from the May previously, we had now got 70 PPI participants, and you can see a bit of a breakdown of that there. We'd also supported 27 study applications, ongoing studies, and wide vascular projects across 9 UK academic centres and with 1 industry partner as well. We sent out an evaluation survey to all the external research teams in April, and 50% responded. The results were really positive. Everybody was very happy with the support they received and said they would like to use the resource again. And in May 2025, 2 years after the registry was established, we sent out a survey to all the PPI participants on the registry to find out how they were feeling about everything. And we got more than half of them responded to that, so that was good. And with the survey results, what we saw was that things were going really well. Everybody seemed very happy with the process of joining. Many were taking part in appropriate activities, and the majority did feel that they were making a positive impact to the studies they were supporting. They were receiving appropriate updates, which is how they knew they were making a positive impact, and that is incredibly important. And 91% said they would recommend joining the registry to other people. So this is us. This is my email address. If anybody would like any further information about the registry or would like a printable copy of the information leaflet to give out to vascular patients, then I'm more than happy to provide that. And just to close, I'd like to say thank you to all of the registry participants who have helped us in shaping our research so far. Thank you.
Thanks very much, Imelda. So, sorry, just got to share our slides again. So what we've been talking about up to this point is really about how we've involved patients in the design of research and how we've actually got all the research funded. I'm going to hand over to Sian now, who's going to talk about sort of the next step, which is about how we've used PPI in actually the delivery of research.
Thanks, Matt. Hi, everyone. I'm Sian Baldock, and I'm going to talk about the PPI design and refinement, specifically of data-enabled trials, focusing on the FAST trial, which Imelda mentioned in one of her previous slides. So in a nutshell, FAST is about screening for peripheral arterial disease, high blood pressure, and abdominal aortic aneurysm screening at the same time. And we'll be doing this over 3 work packages, but I'm going to focus on the 3rd and final work package, which was the main reason why we needed so much PPI input and a national survey, which I'm going to talk a little bit about later. And essentially this was due to the design, which is extremely pragmatic, and it's a cluster crossover design, which results in a really large sample size. So over 260,000 people would need to be invited for screening, which naturally presents logistical challenges from the perspective of research participation and conventional informed consent. And indeed, we know that to be the case from the feasibility study in work package 2, as it caused a lot of disruption to the aneurysm screening clinics. In the context of work package 3, we also need to consider the size of the workforce that would be required at all of these locations across the UK. And this isn't just NHS trusts, we're talking remote locations, often in different parts of the country, which can be quite difficult to get to. And finally, the length of time it would take to consent these patients. Essentially, it's just not feasible. So that's focusing on research participation, but what about data collection and the logistics of that, specifically CRF completion and query resolution? I calculated that this would cost in excess of 52 million, which is just an extortionate amount of money, but we can do it in a much more cost-effective way via electronic data collection. So getting the HESO-NS data from NHS England and then the screening data from the screening programs themselves. So not only is this more cost-effective, but it's also more efficient, meaning that ultimately we can get the answer to the research question quicker for the public. Now, of course, for data collection, data sharing and linkage needs to take place. And what you're seeing on the screen right now is the very first diagram that we put together with our PPI group. Now, ahead of this, we had discussed it at length, but we realized we just needed to get something in front of us to sort of pick apart and try and get the process looking right so that we could put it on a website later. The feedback from this was it needed some work. They recommended that we should use padlocks to communicate security, as that's a little bit more reassuring. And we also needed to make the organizational involvement clearer. So we're back to the drawing board, and this is the next version. I appreciate it is quite small, but what we've done is we separated out the organizations. You can see we've added those padlocks. We got feedback. No, you need to make it even more transparent, separate the organizations out even further and also make it clearer about what data is moving where. And the advice was that color could help with that. So that's what I'm now going to show you is that final diagram that we developed with the PPI group. But I'm also going to use this as an opportunity to explain to you the data linkage pathway as well. So starting with the aneurysm screening program in green, we would first need to breach the common law duty of confidentiality by sending the NHS number and the date of birth together with a pseudonym, so that's that red box, to NHS England, who would then use this information to collect the HES-ONS data, and that's attached to the pseudonym now. And then these two respective parties would send their pseudonymized data to the University of Leicester researchers. And because we have that common pseudonym shown in the red box, we're able to link it. But of course, we don't have informed consent. So the only way that we can breach the common law is if we have Section 251 support. And for that, we need to make an application to the Confidentiality Advisory Group so that they can make a recommendation to the HRA for research purposes. And as part of that application, we needed to develop a national survey with our PPI group to determine the overall public acceptability of the trial design. So that's this cluster randomization, the opt-out versus conventional informed consent, and also the data set sharing. Now, I realise I've not talked about the opt-out approach to trial participation and the method that we would inform men about the research. So that's what I'm going to go into now. And essentially, we'd be doing that. We'd inform men about the research by sending them a research leaflet with their clinical invitation for screening. And the purpose of this leaflet is to provide the top layer information to inform men about the use of their data in research unless they opt out before a defined cutoff date as stated on that leaflet. So men would receive this at home and they can choose to do nothing and their data will remain in the study. They can opt out immediately because the information is on that research leaflet, or they can visit the website and decide later. But ultimately, the decision is theirs. So like the data linkage pathway, we also had to do quite a significant amount of development of that leaflet. So it went through several iterations. And then when we felt like we were getting to the final stages of designing that leaflet, we put together these PPI packs, essentially with the aim to mimic the patient experience. And the purpose of this was to get more accurate feedback so that the group could view the documentation in the same way that men being invited for screening would. And as you can see, I've documented on what was Twitter at the time, and I'm essentially using social media as a tool to evidence the PPI work for the CAG application. So now moving on to the survey design. So just to recap, that was to explore the overall public acceptability. And we were really lucky in our PPI group that we had quite a few people that were involved in business and had expertise in marketing. And they really reinforced the importance of using our logo and the FAST branding. So hopefully you can see from the screen right now that we've attempted to do that. And then we moved on to designing the question structure, which was designed in a layered manner. So we started off with a headline to frame the context. So the purpose of this is to tell the respondent what we want from them as a result of them answering this question. And then this followed by the background information coupled with a diagram to make the information a little bit more accessible and also more easily digestible, given that, there's quite a lot of text. And then finally, this ends with the question itself, and we're using color to break that up. But it wasn't just the question structure that was layered, it was also the order of the questions. So they started off simple and built on complexity. So the questions that is indicated by red, now these focused on reasonableness of the overall trial design. So that's this cluster randomization, the opt-out versus conventional informed consent, and then finally the method to inform men of the research via the research leaflet. And then the second set of questions shown in purple, they came at a different angle. So they focused on the different elements of the data linkage and whether respondents would theoretically allow their data to remain in the research based on those different components of the linkage. The survey was then disseminated via social media, so both Twitter at the time and Instagram, and then the posts were boosted via paid and targeted promotion. So what happened? Well, we found that with more information provided, the reasonableness increased. So by the time that they knew about the research leaflet and they were answering that question, 88.5% found this approach reasonable with the research design. In terms of the data linkage, interestingly, they found it more acceptable that the NHS would be sending pseudonymized health data with the University of Leicester versus the NHS sharing confidential information within the NHS itself. But of course, these are still high percentages. So for confidential information sharing within the NHS, it's still 86%. And then, despite the fact that data received from the two parties, so that's the screening programme and NHS England, so despite the fact that that data would be pseudonymised upon receipt at the University of Leicester, there seems to be a slight reduction in those that would remain in the research due to the linking of that pseudonymised data. As an outcome of the PPI and survey results, we decided to develop with our PPI group a poster to be placed in clinic to act as a reminder. So you can see in the top left-hand corner, we've got an icon to remind people of what the research leaflet looks like. And that would be coupled by a verbal reminder by the screening, the clinical screening staff. So now I'm just going to recap or go over the PPI strategy overview, because there's some other elements to our PPI work that I haven't been able to talk about in the previous slides. So the first thing I want to mention is that our FAST PPI group was a de novo group. So we did have to spend quite a bit of time at the beginning going through the various different aspects. And of course, it was very important that we spent that time to do that, because ultimately that's what led to the high quality patient-facing trial documentation that we designed with them. And this was also in tandem with the development of the survey that we've spoken about. And I really cannot stress enough how much input that the PPI group had into that, even down to the point of, how many options do we give in the answers and how we phrase the answers. So all of that. So we saw that as an opportunity to perhaps publish with the PPI group. So we put in a last minute ethics application. And then finally, in the final stages, I realized that our PPI group had essentially become experts. So to get some additional PPI input and expand the geographical reach across the country, we did some extra exercises. So in a sort of spoke hub type approach, I identified a PPI champion who essentially passed on various materials that had been developed. And then they found another PPI champion. So we got a sort of link effect. And that was really effective, because in the space of 1 week, we got 26 responses. We also engaged with PAD patient charity ambassadors and also cardiovascular theme Facebook groups that had a reach in excess of 5,000 people. And all while doing this, I was using social media as a tool to create an evidence package for the CAG application. And as an outcome to this for the CAG, we got absolutely no queries, and we were really fortunate to be taking part in the CAG pilot at the time. So we got verbal feedback on the quality of the application too. So we met all of our milestones, which was absolutely great, but unfortunately we were unable to proceed with that current design because the aneurysm screening program hadn't recovered sufficiently to be able to adopt the new type of screening post-COVID. So we had to pivot. And as part of this redesign, we had to redo this process in some ways. We did do it in a more targeted PPI way to redesign it to PADS. But we've had success for a second time. And once again, we got absolutely no queries and commendation on the quality of the PPI. So hopefully I've just demonstrated from these slides today that a really well thought PPI strategy can really help with the design and refinement of complex data trials, and of course, really help with approvals. Thank you very much.
Thanks, Sean. So I'm just going to finish up and spend a couple of minutes. So we've talked about how PPI can help in terms of setting the agenda for research, designing research, and how you expand that up, and then how you use it to successfully deliver trials. So, of course, not everything works perfectly. And sometimes when you're actually working on a project, you do run into trouble, and we do always learn quite a lot from our challenges that we face. So as surgeons, one of the things that you have taught very early on is that if you get into trouble in an operating theatre, you ask for help. And it's very much the same here. So we've got a project funded by NIHR HSDR programme, where what we're doing is we're linking together data from the NHS abdominal aortic aneurysm screening programme with clinical practice research data link, so that's primary care data, and bringing it into the University of Leicester. So that's basically a big data science project. Now, this has been going on for some time. The initial design was back in 2017, as shown by the pin diagram at the bottom. And we eventually got NIHR funding in 2019, but of course, COVID got in the way a little bit there. And at that time, the aneurysm screening programme was under the governance of Public Health England, which was dissolved during the pandemic and moved into NHS England. And then our project started in 2022 after COVID. By 2023, we still didn't have any data. And then in early 2024, we still didn't have any data. So what we did is we went to our study steering committee and we said, well, how might we be able to resolve this? And what we actually came up with is this. So these are 4 letters. The 2 on the right are the least important ones because the 2 in the middle are the most important ones. You're not expected to be able to read these, but the one on the left is from our PPI group. Sorry, the one on the left is from our lay representative on our study steering committee. And that was basically a letter of support. And then the one on the right, the second big one, that is from our PPI group. And we got our PPI group to basically write a letter. And these 2 letters went to Cathy Rowan, who's the director of the HSNDR program. And we copied in Lucy Chappell, the chief scientific officer. And then we also sent those 2 little letters on the side, which were from the steering committee and myself. So these letters were sent on Monday. On the Thursday afternoon, I had an email. And actually, what had happened was the HSNDR program had got in touch with NHS England, and we'd been assigned basically a manager from NHS England to help us get the data moving. And so, and I firmly believe that was because we had the support and input of our lay representative on the study steering committee and our actual patient advisory group for that project. So that has been utterly invaluable, and now the data is basically arriving tomorrow. So, you know, that is how PPI can really help you once you've got a project up and running. And that's the end of our slides, and I think we're now going to move on to a Q&A session.
Thank you, Matt, Thanos, Imelda and Sian for a brilliant, fantastic presentation there. We've got some questions that people have been posting, so I will just go through those. So first question is, Professor, please, what are the impact of proton pump inhibitors on cardiovascular and bleeding outcomes in coronary heart disease patients undergoing percutaneous coronary intervention?
Okay, I'm not sure I know the answer. That's slightly outside of my field of expertise. We're vascular surgeons, so we're the plumbers basically. We deal with blocked and burst pipes. PCI, percutaneous coronary intervention, is what the cardiologists do. What's the impact on proton pump inhibitors on bleeding risk, I think was the question. I'm not aware of any association. Thanos, I don't know if you know of any. Sorry, I'm putting you on the spot as well. The simple answer is I don't know the answer to that one, and I'm very sorry.
Absolutely fine. Thanks, Matt. So the next question is, how can we ensure diverse and representative patient groups are involved in the research process? It is important to consider how to reach marginalised or vulnerable groups and avoid exacerbating the digital divide when using technology for involvement activities.
Yeah, and this is obviously very important. And in our patient population, you know, we're very aware of this. I might ask Imelda to come in a second. She's got her hand up already. There we go. I'm going to hand over to Imelda then.
Thank you.
Oh, that's sorry. No, it was the pointer. It was the pointer. It looks like a hand on my screen. Sorry, Imelda. Yeah, so you know, this is really important, and you know, particularly for vascular disease, you know, we know that you know, there are inequalities in vascular disease because it tends to affect those in the sort of most deprived sections of our population from the more deprived areas and communities, and there are also differences in terms of sex and race in terms of your risk of disease, and you know, they are very different. So how we get them involved in PPI is really around those things that Imelda was talking about in her presentation about the things we know that don't work. You know, if we just send out something on one of the social media channels, you know, if people aren't looking at social media, you're not going to get them. And then you're going to get a skewed input into your research, which is probably the really bad thing. Imelda, I don't know if you've got any specific tips. I haven't given anything specific there about how we've managed to do that in our registry.
Yeah, well, sort of diverse, particularly in terms of ethnicity and a little bit in terms of gender as well, it has been tricky, and it's been another barrier really to getting people involved within this patient group. What I would say is that the absolute starting point that really helped with the PPI registry was being able to contact those participants who had already taken part in research personally and directly target them. So I know that we have underrepresentation of some groups within research itself, but you're going to find more people from those minority groups within the research studies. And if people are putting on their consent forms an optional consent to contact patients for further research later on down the line, or maybe even add a bit about PPIE and start getting into the habit of doing that on our consent forms, then we're going to be more likely to be able to target patients more appropriately. So I would say that that's a real key.
And I think this is an area, that we do need to work on. We recently submitted a funding application where we proposed a new style of PPI that we referred to as proactive PPI. And that wasn't about recruiting people into groups to be contacted at a later date, but that was about doing the PPI proactively as you're doing the research. So, asking people as you're recruiting them what they think about, what you're doing. Unfortunately, the application didn't get funded, but the PPI got very good feedback.
Thanks, Matt. Thanks, Imelda. The next question is, have you engaged the support of GP community nurses, care home managers, and staff and patient organisations in recruiting for patient participants?
I think the simple answer to that is no, but it's a great idea, and we might steal it if that's okay. Whoever put it up. Oh, Thanos has got his hand up here.
We have done this before in an NIHR RFPB award, not a big national randomized control trial. And the way that I was able to do that, after having tried through emails, telephone calls, etc., we created a WhatsApp group with GPs in the East and the West Midlands. And somehow this turned up to be a very efficient way of communicating with GP practices. And they did find dozens of people interested in helping us with the PPI component of our work.
Thanks, Thanos. I've got a question for Imelda. Do the PAD PPI members undertake any training when they join the group?
Yeah, so there's no mandatory or formal training currently on the registry. I'm currently working with the participant advisory group to try and build up a very sort of basic explanation, sort of a patient pack, a participant pack, if you like, that people will receive when they first join the registry. What happens at the moment is that they will contact me and then I'll get in touch personally, talk to them via phone or on Teams or something like that, and explain what's happening. They ask any questions they have. If they're concerned about joining online groups, then I will offer them sessions to beforehand to get in a bit of practice, get used to the way it all works, and know how to raise hands and things like that. But no, there is no formal training at the moment.
The training aspect is really important though, and I did a PPI group where we were asked, we were using our PPI group to help inform a non-inferiority margin for a trial. So a concept that is not necessarily that easy to explain to anybody. And we had to go through a whole sort of training process about how do you not only do we have to do non-inferiority margins, but we had to do the difference between superiority, non-inferiority, and equivalence trials. And pretty much what we had to do is we had to do sort of separate sections of the session to actually train the PPI group about all of those different aspects of trial design before we could actually get around to asking them the question about what do you think is a reasonable non-inferiority margin. Yeah, training very important.
Yeah, definitely. Thanks, Matt. A question for Sian. It looks like PPI input was mostly in the final work package, but what might involvement of people with lived experience have looked like for the earlier stages of the work? And would there have been merit in partnering with people earlier on in the work too?
Yes, so I didn't mention this. So we had the same PPI group also for work package 2. And Matt, you can explain a little bit more about the pre-bid.
Yes, we did quite a lot of work around that program in terms of PPI leading up to it, because it was a pretty major change to the way things would happen. And there were lots of things such as, so we haven't talked about work package 2, which was actually another cluster randomized trial. And we did a few things in there that are perhaps a little bit non-conventional that we had to sort of get through the PPI process first. So we basically did the cluster randomization, and people weren't told that they were being randomized into a trial and or having their data gathered for research until they arrived at the clinic, because we didn't want to bias the outcome, which was attendance for screening. So, I mean, we got all the appropriate ethics approval for that, but we did do PPI to feed into it to demonstrate that actually that was a reasonable approach, largely because it was very low risk. We weren't, randomizing people to deep brain stimulation without consent or anything like that. So there was PPI there, and then also before we started the whole program, there was quite an extensive PPI process, really to answer that very essential question: is this daft? And I think that's the most useful question you can ask a PPI group sometimes is, I've got this great idea, but actually, is it a completely stupid idea that we should just not take any further? And my experience of PPI groups is that you want the ones who are going to speak up and tell you you're wrong and tell you you're being stupid, because actually that saves you vast amounts of time further down the line when a funding committee has, strangely enough, told you after you've written 20,000 words, this is stupid. You'll get the answer much quicker from a PPI group.
Excellent, thanks for that. I've got a quick thank you here to Imelda for her excellent vision and perseverance in expanding the registry. Next question, have you ever included partners, caretakers, families of patients in the PPI aspects of the studies?
Yes, so the example I gave at the end, actually that PPI group is made up of people with the condition plus partners and carers, mainly because this may be a bit sexist of me, but the condition mainly affects men, and men often don't tell you what you really want to know. So including their partners means that you get probably a better picture of actually what's important. Sorry, I appreciate that's probably completely prejudiced, but I think for me, that's one of the values of having these people in the PPI group. You often get people who tell you things that perhaps your patients might not.
And if I might add also, as part of the PPI champion type approach with the spoke hub model, I found that the people that were completing these questionnaires that I put together were also writing little notes on it for me saying, I'm the wife of someone who has been screened. So it was, whilst I hadn't directly asked for that, and perhaps I probably should have in hindsight, so I've learned from that, it was really helpful with people writing those notes. I think it was maybe about 3 or 4 people. Obviously, we got 26 responses, so not a large proportion. But, I did have women partners, were responding about that they know people that have had this screening. So that was really helpful.
Yeah, thank you. Imelda?
Yes, just to say that the patients and their carers are really important, family members. And on the registry, we also have members of the public who don't have any vascular conditions, but are interested in research, want to have a bit of a say in what happens in the health system. And I think it's really important to get people who don't necessarily have lived experience of conditions, sometimes having their voices heard, because they could have this experience, or they could know somebody that will in the future. And these are the people that are walking in and we're asking to take part in our research, quite often are brandly new with their diagnosis. So it's going to be those members of the public that you're trying to reach in the first place. So everybody's voice is important in this.
Absolutely. Thanks, Imelda. For Matt and Sian, how have you communicated to PPI groups when there's been roadblocks in the research? I'm aware that challenges of research can be disheartening for participants.
Yeah. I
feel like I've had quite a lot of reflections about this, and I think sometimes, I'll admit it, I don't think we've always done it the right way. Whether that was that wasn't purposely done. Sometimes, time is a massive factor in research delivery. As we all know, it can be really challenging when you've got these milestones to hit. And but that I think is the reason why we wanted this PPI registry in vascular in our team, essentially, because I was doing some reflecting on this process, that it has been really difficult. Because I was the trial manager when I was at the Leicester Clinical Trials Unit for FAST, overseeing this programme. And one thing that I was acutely aware, whilst we were doing the overlap of Work Package 2 and Work Package 3, obviously we were in contact. We had another PPI coordinator at the time who was helping us out, and they were great at liaising with the PPI group. But when we encountered these, the roadblocks, shall we say, when we hit all the milestones, so we found out that, I think it was September 2022, we realised we had to pivot and we had to regroup a little bit. Was it earlier than that? So we found out, was it the final milestone was December 2022? And that was when we found out that the aneurysm screening programme wouldn't be able to continue with the design. And it took around about 9 months until we had the final decision from the screening programme that we couldn't go ahead with that design. And in that time period, we were working with all the screening programmes across the UK to try and find a way forward. We did lots of surveys, and Luke Ingram, one of the trial managers at Leicester C2 who took over after me, did a number of deep dives with all the screening programmes. So we really tried to work through that process. And I'll admit, during that period, it was really tricky because we didn't know. It was sort of a case of there was no real update. We had to it was a long process. And then once we found out that we couldn't go ahead, we had to explore different options. So one option was using digitrials. And at that point, I think from what I remember, we did have a meeting with the PPI group.
Yeah, and it was all about being honest, really. And, not trying to pull the wool over the PPI group's eyes and say, it's all going wonderfully, that sort of thing. We let them know. We didn't have the same frequency of PPI groups when we were kind of doing that, because with the feedback we were getting was they don't want to just turn up to a meeting and hear we're not there yet or anything like that. But what we did is we used the PPI groups very much to kind of, again, we were in a sort of fairly active stage of trying to do a redesign. And it was, again, it was that sort of, here's an idea. And then it was running that idea fairly quickly past the PPI group to be able to go, this is what we're thinking of doing. Does that make sense to you? And, there were some things that the PPI group sort of thought were reasonably sensible. There were some good suggestions from the PPI group, which we followed up. And ultimately, when it came down to it, it was a lot of questions like, we had to shift from using the NHS to do the clinical delivery within that program to using a commercial NHS partner to doing the screening. And it was things like, what do you think about these private companies that, now deliver healthcare services? Would you trust them to deliver a sort of clinical service as part of a research trial and things like that? So had we not been honest and told them these are the problems we're facing, I don't think we'd have got the right answers from all those sort of engagements. So yeah, it was about keeping them informed. In the diagram I showed at the end where we had the data problems, we did sort of suspend the PPI groups there because they said, well, again, if we're not making any progress, we want to see some results and get some data and things like that. We did actually use them to redesign another research project that was related to it, that was actually came from that PPI group, and that's now a program grant application. So directly from that PPI group, during that sort of lull phase where we didn't have too much to talk about, they pretty much just sort of stuck their hands up and said, how would you answer this research question? And I sort of thought, well, that's a really interesting research question. It's now become a program grant. Not funded yet, but hopefully soon. So yeah, there are some advantages to delays in that you get a bit more thinking time.
If I also may add, in terms of FAST, we were also really acutely aware just how much time the PPI group had already dedicated to sort of, should we say, the old design of FAST. And at this point, we were also really mindful of our NIHR budget. So we were trying to do this in a really streamlined way to with respect for the budget, but also respect for the PPI group's time. We wanted that input to be valuable at the right points, because sometimes it's not, we don't want to have PPI meetings for the sake of it. It has to serve a purpose. So that's why, as part of the redesign, we did targeted PPI. And what I mean by that is we went through our national survey, and what we did is we overlapped the similarities and the differences of the new design versus the old design, because the PPI group had already given us so much important feedback, and also the survey respondents had too. We didn't want that to go to waste. So we did a compare and contrast exercise, so that when we regrouped with the PPI group as part of the redesign process, we did have to, because of that delay, we did have to go through the old design saying this is what we did. As a reminder, this was the survey results and this is what we're thinking. But there was still, at this point, quite a lot that the PPI group could still help with in the refinement of PADS in its final stages. And we did take on quite a lot of feedback with that in respect to the fact that the screening partner would be sending out the invites with NHS logos on it, which is what part of their standard process at the moment anyway. So yes, it was about preserving budget, being really respectful of their time, and making sure that it had its purpose. And I'm really, I feel like that's what we achieved, even though the process has been long. And I think as part of that, the reflection is the reason why the registry is so important, and having Imelda on the team leading this now.
Thank you. Thanks, Sian. We've got a few more questions. If you guys are happy to stay on for a bit longer, I'll go through those. So do you have any advice for teams setting up and maintaining a PPIE register, please? For example, having a dedicated person or amount of time needed to be ring-fenced to dedicate to it?
So I'm pointing to this way because that's where Imelda is. A dedicated person is the key thing to this. And the way that that's been funded is basically through NIHR grants. So that big list I put up at the beginning, you fund your PPI register coordinator through your grants.
Yeah, no, that's great. Thank you. The CAG study sounded great. Did you have previous experience of CAG or use any particular resources?
I'd had previous experience of CAG over many years, and what my knowledge of CAG from previously was that, again, it's all very well showing local support for your project, but what they want you to demonstrate is broad geographical support from across the country, and that's partly why we sort of went down the route of making sure that it wasn't just our local PPI group, but also we had those national surveys with that sort of broad geographical reach, just to demonstrate that this was a reasonable approach across a cross section of the country. So yeah, that was partly based on my CAG experiences, but we did learn an awful lot from actually doing it again. What would I do differently next time if I was going for CAG? I'm not sure I'd do too much differently. I might try and expand it a bit more and do even more. But yeah, I think, and that was the key thing for CAG. It didn't matter kind of what we'd written in terms of a protocol, but how the data was being shared and things like that. Had we not demonstrated public support, I think we'd have been in trouble.
I think also, so I hadn't done a CAG application before, so I wasn't really sure what to expect. And I was also quite, I'll be honest, really nervous about it, because I knew the Section 251 support was one of the key milestones for progression. I put myself in the shoes. I was like, well, what would I want if I was a member of the public? And that is what I want. I wanted to be as thorough as possible as doing this PPI. And one thing I didn't mention is I even went into community locations. I went into pubs and I spoke to people, and I also got these questionnaires and leaflets under people's noses, interrupting their drinks and meals. But what I'm trying to say is, yeah, I hadn't done a CAG before, but, it's about, when it's data trials, thinking about what would you want if that was your data?
Yeah, no, that's great. Thank you. Facilitation skills are crucial in PPI, and developing skills and activities that encourage people to speak however they prefer is crucial. Emphasis should be facilitation rather than the easy to ignore patients.
So as a response to that, so we were also mindful that some people possibly didn't want to actually speak in some of the meetings. I think some people are more comfortable with that and others less comfortable. So one approach that I quite like personally is at the end of a PPI meeting is saying, please get in contact with Imelda afterwards, or myself, to essentially, sometimes people, it's a lot of information sometimes in these meetings, and you're listening to what other people have to say, and sometimes you haven't fully formulated what you think about something. It's quite difficult sometimes to come up on the moment with what your thoughts are to something, and hearing other people's viewpoints. So I'm a big fan of remote correspondence, or if someone wants to sort of pick up the phone, and even if it's an email saying, can I speak to you on the phone about this, then I think that's really helpful, to have that sort of approach to get to essentially hear from as many people as possible who want to have their say.
Brilliant, thanks, Sian. Did you include any PPI members who have visual difficulties?
Oh,
Not that I know of. Imelda, you've just unmuted yourself. Are you about to tell us?
No, no, we haven't as yet, on the registry at least, got anybody with visual difficulties that I know of. However, we are looking to sort of get, I'm going to be doing a bit of accessibility training. I'm trying to link in with some of the groups for again, underrepresented, so some of the community groups of people with learning disabilities and people with sort of just people that you see less in these PPI groups, and the groups that represent them. So hopefully we will see some improvement in that within the sort of next 12 months or so. And it's certainly one of my aims.
Lovely, thanks, Imelda. And finally, it's more of a comment than a question. Just a huge thank you for your honesty and openness in your reflections on what worked well and what worked less well. I don't think any of us always get involvement right, but reflections like this are so valuable for our learning as a community committed to involving people in research. Thank you. Oh, we've just had one more come in. So, Professor Matt, have you thought about British Heart Foundation, as I receive regular magazines and your article would be good to be published about the PAD study?
Yes. So I have quite a lot of funding from the British Heart Foundation and do communicate reasonably frequently. Was the comment around should we write something for the British Heart Foundation? I think that's what it was.
Yeah, let me just find it again. So, have you thought about British Heart Foundation, as I receive regular magazine and your article would be good to be published about the PAD study? Yeah.
Okay. Yes. British Heart Foundation tend to, they'll do press releases about things they funded. The PAD study is actually funded by NHR. So, but they are interested. So, I shall ask them. There we go.
Yeah. Brilliant, thank you. And then one final question. We have an ophthalmology PPI group who you could possibly reach out to. So somebody has commented there. So if you would like to email that in, whoever's posted that, then to the group, we'll include an email in the email that you get after this. Thank you. That's all of the questions. So we can have the next slide, please. Thank you again to the team for a really brilliant presentation there, and thank you to all of our attendees for some great questions as well. I just wanted to signpost you all to the upcoming events in this series. So we've got one in January, February and March. You'll receive an email after this with the recording, the slides and an evaluation form, and we'd be quite grateful if you would take some time out to complete that for us, because it will help with our future webinars that we'll be creating. So thank you. Thanks again to the team. Thanks, everyone.
Right.